Okay, the other thing we have to consider in the thoracic spine are the ribs. And a lot is made of rib dysfunction, and if you examine rib mobility, particularly osteokinematic mobility, by palpating the movement of the angles of the rib and seeing whether they move during inspiration and expiration, you're going to find an awful lot of hypomobilities. You will reduce the number of rib dysfunctions you have to treat if you don't examine these joints until you've treated the spinal joint. Because in a lot of cases, this hypomobility is due to increased tone in the muscles attaching to the rib as part of the facilitated segment that's often coming from the spinal joints rather than the costal joints. So my advice is deal with the spinal problem first and then look at the rib. Okay, to examine the rib, it's difficult to actually do passive physiological movement testing. It can be done, and you do it on the neck of the rib. So I can come onto the neck of the rib and basically push it forwards and upwards, so I'm rotating it to bring the front of the rib down. So I will actually be testing expiration, the osteokinematic movement for expiration by doing so. If I push it in the other direction, then I will basically be testing the osteokinematic for inspiration. If we find that the osteokinematic is hypomobile, that there is lack of bone movement, then we need to come in and check the arthrokinematic glides. Now we're dealing with two joints here, the costovertebral and the costotransverse joint. And the glide for the rib is actually dorsolateral anteromedial along the transverse process. And there's a small amount of this glide. As you come medially, of course, the head of the rib will abut the disc and the adjacent vertebra. As you come out, you'll be stretching the joint capsules. But we've got enough movement that we can pick up normal or abnormal end fills. So to test this, if I want to do a dorsolateral glide, I'm going to come onto the medial side of the angle of the rib, this time on the left, and I shall be pushing it laterally, like so. Now I need enough downward pressure or anterior pressure to maintain contact, but then I'll just slide it laterally. But as I do that, of course, the vertebra will tend to rotate in the same direction, so I need to stabilize that by putting my hand along the transverse processes on this side. So I stabilize the vertebra into the opposite rotation, and then I can come onto the medial side of the angle of the rib and basically push to produce that glide. So I'm pushing it laterally, and the transverse process of the vertebra will guide it dorsally, like so. If I want to test the anteromedial glide now, I shall come on, I'll take this side of the ribs, I shall come onto the lateral side of the angle of the rib and basically push it anteriorly and medially. And of course, as I do so, I'm going to shift the vertebra in the same direction. So I need to stabilize that, and I can do that simply by coming a little bit further up the bed this way, stabilizing across the rib that way, holding it into this rotation and down, and then coming onto the angle of the rib with the other hand, like so, and basically pushing it down and forwards, anteromedially. There. Okay. Now, if we have an osteokinematic limitation of movement, the physiological movement is limited because we found that as we was rolling the rib, but the arthrokinematics were not, then essentially again we have a myofascial restriction. If I was you, I would go back to the spinal segment, make sure that the joints are okay, and if they are, then you can start looking at stretching techniques for these, for the muscles controlling the rib movements. But if we found that this was actually a hypomobility of articular origin, then we can come in and glide these joints. Now most of these unfortunately are subluxed, and I will show you a distraction manipulation for this joint, as basically these are peripheral joints rather than spinal, and I'll show you a simple distraction manipulation that will get both the anterior and the posterior subluxations.